please welcome Dr. Shaleen Agarwal from Max New Delhi. He would be speaking on the intraoperative bleeding in cases of liver dissections. So, Dr. Agarwal, over to you.
So thank you, Dr. Sain and Dr. Kapoor.
So before Shaleen starts, let me again interrupt. Shaleen is again one of our former fellows from HPGH, and he is now one of the member of one of the leading liver transplant groups with Dr. Subhash Gupta, which was earlier at Apollo, but now they have moved to Max, and Shaleen has been participating in all our online as well as offline. The offline activity is the Jaipur Surgical Festival. I will project information about that also in between, which we do every first weekend of December. So this year it is 6, 7, 8 December, and the theme is complications in surgery. Shaleen, please.
Thank you. Sir, can you allow me to share my screen? It says host disabled participant screen sharing. So the topic allotted by Dr. Kapoor to me today was to talk about bleeding during liver resections, but I've made it a little wider. That is all kinds of liver surgeries that involved any kind of parenchymal transaction. So just a little background because I believe this meeting is more for the students and for the MCH and DNB fellows in surgical gastroenterology. So I may bore you with few of my slides. So liver is a highly vascular organ. You all know that. It has dual blood supply, that is via the hepatic artery and the portal vein, with a blood flow of around a liter per minute on average. And it is evident that liver, although it constitutes only 2.5% of the body weight, still receives 25% of the cardiac output. Therefore, it's a highly vascular organ, and therefore liver resection was a surgery which joined the gamut of surgeries performed by general surgeons very late. Although the first liver resection was performed by Karl Langenbach in 1888, but it was a procedure that was fraught with a lot of blood loss, lot of morbidity and mortality, and therefore very few people ventured to perform a liver resection till the delineation of the functional, or what we call the segmental anatomy of the liver, in the 1950s. And even after that, till a few decades back, it was still considered a daunting task, simply because it was associated with a lot of blood loss. So what are the reasons and predisposing factors that are responsible for bleeding during liver surgery? Mainly, as I've just said, that liver is a highly vascular organ. Then transection of the liver parenchyma is not similar to cutting other tissues usually dealt by the GI surgeons. So you cannot just cut it with a cautery or with a knife. So we have to have techniques and devices to transact the liver. And then, of course, the poor understanding of the segmental functional anatomy of the liver. So here I've given a few pictorial diagrams about the functional anatomy of the liver. But understandably, even after so many years, I find it's so easy on the paper, on the book, in a book chapter, to understand the liver anatomy. But while you are actually doing in the OR, sometimes it really confuses me. Even at this stage, I've been doing this for the last 10, 12 years now continuously. But segmental anatomy is a topic which I would say I'm still learning. So actual understanding of the functional anatomy takes a lot of time. You have to study not only the books, but also the 3D anatomy of the various CTs and the MRIs that are done on patients. So you have to sit down with your radiologist, and the newer technological tools are definitely helpful. Continuing with this on the same line, then distortion. Once you have to understand the anatomy, the normal segmental anatomy of the liver, and at the same time, because you are operating on a pathology, so which often causes the distortion of the normal anatomy. So you have to realize and understand the distortions caused by the lesion that you want to resect before you actually venture into the OT and operate upon that particular lesion. And then both the size and the location of the tumors are a consideration, because size can lead to the pushing of the hepatic veins to one side, and at the same time deeply located tumors, especially those located near the apex, that is between the insertion of the hepatic veins, the right, middle and the left, into the IVC. Those are considered to be difficult for resection because there's very little space to operate. Visualization is poor, and then the veins are often stretched on these tumors. So location, I would say, is more important than the size of the tumor. Bleeding from hepatic veins in general is the most common source of intraoperative bleeding during liver surgery. And the simple reason is that because these veins are encountered deep in the operative field, and once the bleeding occurs, the blood just keeps on welling, and it's difficult to identify the source of the bleed. Sutures tend to cut through because these are very thin-walled veins, and so it's a kind of panicky situation that the patient is continuing to bleed and you cannot locate where the blood is coming from. Cirrhosis and portal hypertension adds a totally new dimension to liver surgery, but yes, because it's become CLD so common these days, and you find patients, and as we all know that HCCs and cholangiocarcinomas are more often seen in patients with a background cirrhosis. So often you are called upon to operate upon these tumors, and now liver resections and cirrhosis is not an uncommon thing to be done, but yes, it is even more risky, or I would say more complicated and difficult to operate in the presence of underlying portal hypertension, simply because of the risk of bleeding. The reasons for the excessive bleed during cirrhosis and portal hypertension is, one, you can have vascularized perihepatic adhesion, especially if the patient has had a previous cholecystectomy or any other form of upper abdominal surgery. Cirrhotic tissues, as we all know, tend to become hard and brittle and require more energy for transaction, but at the same time, the hepatic veins continue to remain thin-walled and are often engorged, and therefore tend to lacerate and bleed very easily. Coagulopathy, one must understand, is not the primary cause of increased blood loss while you are operating upon a cirrhotic patient. Forget about the INR values. Even with the INR value of 2, 3, don't blame your coagulopathy for bleeding. Coagulopathy actually sets in once a large amount of blood has already been lost, and it is the initiation of the coagulation and then the fibrinolysis cascade, and when the patient starts going into the DIC, that you can actually blame coagulopathy. But this is very late in the whole gamut of events. Bleeding during liver surgery, as with any other surgery, tends to impact the outcomes. It's a major cause of postoperative morbidity and mortality, especially when we are seeing more and more geriatric patients in our practice. Not most, but many of them do have underlying chronic liver disease, and they tend to tolerate major blood loss poorly. So you can have adverse outcomes when you are operating upon these patients. Messy surgery can lead to post-resection liver failure in a cirrhotic child's well-compensated patient despite an adequate remnant of more than 40%. So blood loss per se can lead to post-resection liver failure, and then when you're operating in a bloody field, you can damage other veins or vessels, leading to devascularized areas in the remnant, and that is another major cause of post-resection liver failure. And then once the field is messy, you don't know where the bile ducts are. The cut surface bile leaks are quite common, leading to bilomas, bile peritonitis, and subsequent sepsis, which is the ultimate common pathway for the demise of these patients. So how do you control the bleeding? So prevention is the goal. So prevention is the best form of treatment. So keep your bravado aside. The role of training and mentorship cannot be overemphasized. I am still learning, and I believe everybody should follow that. Start from easy cases and then gradually go for increasing degree of difficulty. Knowledge of segmental anatomy. Do not think that you have read the book and you have seen the 3D images and you know the segmental anatomy. You have to actually know the segmental anatomy of the liver like the back of your hand, and that you learn gradually with every kind of liver resection or liver transplant living donor that you are doing. So as I just mentioned, so case selection should be very judicious. Start with easy resections such as the left-sided resections. Avoid cases with the portal hypertension, cirrhosis in the beginning, and the tumors located in the superior segments of the liver, such as the segment 4A, 8, and 7. So start with peripherally located tumors or segment 2, 3 tumors, and then move on to the more difficult lesions. Meticulous preoperative planning is essential. Study the imaging multiple times and sit down with your radiologist. Now we can have 3D reconstructions. Even the images can be rotated on the console. So study from all angles before you enter the OT. And often we have found that getting a CCT as well as a CEMRI is very helpful in decision making as well as the surgical planning. 3D reconstruction, there are a lot of softwares available, especially the MEVIS, which is very popular. It's very helpful, but it is not mandatory. And now we have newer technologies such as the holographic technology, where you can superimpose the radiological image in the actual operative field. So newer and newer things are coming, but I believe that the basics cannot be left behind, and knowledge of the segmental anatomy and then starting in a graded fashion is the key in getting into tough situations where you have a lot of bleeding during liver resection. So anatomical resections are easier. So try for segmental or like segment 2-3 resections, and they are associated with less blood loss compared to non-anatomical resections. And I would like to mention that many times during an extended cholecystectomy, I found that segment 4B5 was easier than doing a wedge, simply because I was not clear in which plane I was going. But yes, that is just one example. Embark on minimally invasive approach. It is the in thing, and everybody wants to do it. But I would suggest that one should have some initial experience of open liver resections, because it makes your life very easy during when you just shift the gears to the minimally invasive side. Arrange adequate blood products, because you never know when you land up in a tight situation. Having trained assistants is a boon, and I've realized so many times that when we have these trained MCH fellows helping us, they are full well experienced surgeons. So it's really helpful when you are doing liver resections. Vascular instruments and clamps should be available in plenty. Two well-functioning suction sources. Suction is, I think, this is the most important equipment during surgery when you are talking about intraoperative bleeding during liver resection, because sometimes the blood loss is massive, and you leave the blood loss on the for the anesthetist to control the hemodynamics, but you have to suck out and then see the bleeding point. Of course, if you cannot see it despite suctioning, then pack and wait for some time. That is the most important step to be done at that time. But at the initial, when the bleed starts, if you have a good suction, it can make all the difference. And intraoperative ultrasound, I found it a useful tool because it delineates the segmental anatomy better. So components of a liver resection with respect to bleeding. So I would divide a liver resection into 4 components: exposure and liver mobilization. So unless you are dealing with a major portal hypertension kind of situation, major bleeding is unlikely during, although we have seen, especially in transplants, that even at the skin incision, patients have abdominal wall collaterals and they can bleed massively from that. But I'm talking about in a general liver resection in non-cirrhotic patient. So exposure and liver mobilization is usually not associated with any kind of bleeding, unless you're going very fast and you inadvertently injure one of the hepatic veins towards the end of the right or the left triangular ligament mobilization. The next step is the dissection of porta hepatis. Again, major bleeding is uncommon unless there's a prior surgery, post cholecystectomy patient with lot of adhesions, the field is not clear. Then you can damage one of the portal vein branches, the right or the left, depending on what kind of resection you are doing, or sometimes one of the hepatic arteries. But again, this is an uncommon situation. The next component of a liver resection is dissection of the liver from the IVC, especially when you're doing a right-sided resection. And here you can have bleeding, and the source of bleeding in these situations is laceration or avulsion of an inferior hepatic vein, which usually happens because your assistant cannot see from the left side and tends to apply more force, and they just get avulsed from the IVC because they are very short in length and very thin walls. Second cause for bleeding or the laceration of these veins is that you have taken control of the hepatic vein by ligatures or clips, but these clips and sutures, not sutures, but ligatures tend to slip, which I'll be showing in one of the subsequent videos. And then, so there can be significant major bleed when you are doing an IVC dissection or the retrohepatic dissection, and this is from the IVC and the cut hepatic veins. Parenchymal transection is the area where the major blood loss is encountered by majority of the surgeons when they have, in their experience, including myself, when you tend to injure one of the segmental hepatic vein branches, and then because they are located deeply, once you have moved towards the segment 8 area, and it's difficult to visualize these veins, and the bleeding can be really massive, although it's a venous bleed, but since it's in direct communication with the IVC, so it's a direct bleed from the central vein. I would see the blood directly just wells up from the IVC. So steps in the OR, as I said, adequate exposure. When you are doing it open, give a liberal incision. No point in doing it through a very small incision. Better to do a minimally invasive, adopt a minimally invasive approach in that case. And you should have good retraction. So the retractors that we use are the Thompson and the Omnitrack, but there are many brands and types available. Whichever suits you, use that, but get a good exposure so that in case you have a bleeding, you can just bring out the liver, pack or pump press. So it's very helpful. Use of headlight and magnification, I find, and I think every liver surgeon find it's a kind of mandatory thing to have a headlight and magnification when you are doing a major liver resection. Maintaining a low CVP, we know it from times immemorial, but I would say that now there's so many reports that especially in prolonged resections, low CVP can be detrimental. It leads to ischemic injury, and you can have deranged LFTs, especially the enzymes in the post-operative period. Lactates can go haywire. So don't really target for very low CVP. We don't even think about CVP these days during liver resections. Just try to maintain a normal CVP. It should not be high, but normal. Low CVP, I don't think it is really that helpful. It cannot replace a meticulous surgery. Pneumoperitoneum is a surgeon's friend when you are doing a minimally invasive liver resection, because it reduces the blood loss and chances of embolism, because CO2 is easily absorbed. Liver mobilization, you have to divide the coronary and the triangular ligaments depending on the tumor location. Do it in the early part, except when you are dealing with a large right lobe tumor adherent to the diaphragm, where you adopt the anterior approach. But in all other cases, try to mobilize the liver so that in case you have a mishap, the liver can be quickly brought out into the operative field from the death, and then it becomes much easier to control the bleeding in such situations. So dissection of the porta hepatis and flow control, this is, I think, a basic step when you are doing a liver resection. Different approaches have been described, the intrafacial versus the extrafacial or the Glisonian approach. I have used both, although I'm using intrafacial approach more often because that is what we do in liver transplant also. But the extrafacial or the Glisonian approach is a very good technique, and it's very easy. You just can do any kind of bisegmental resections. I've never done a segmental resection through the Glisonian approach, but anterior sectorectomy, posterior sectorectomy, once the area to be transected is delineated very nicely, and then you can get an exact vascular control without impeding the vascular control to other parts of the liver. So this is just a picture that I've shown. I don't have a video of because I'm poor at making videos, but this is a very good approach. In this picture, it's been shown that both the anterior sector and the posterior sector pedicles have been looped and can be clamped when you start transection. And hanging maneuver is very useful, especially when you are doing liver resections for right-sided large tumors, and because it protects against tumor rupture and bleeding from the tumors while you are trying to dissect large tumors. So hanging approach introduced by Professor Bilgitis, I do it in almost every case when I'm doing a right lobe liver resection. So coming to the steps for stopping or controlling the intra-bleed during liver resection, basic step is the vascular control. Types, inflow control, what we call the Pringles maneuver, and all of us do it routinely. Then the other components of vascular control are total hepatic vascular exclusion, which includes inflow occlusion as well as clamping of the suprahepatic and infrahepatic IVC. That is, the total hepatic parenchyma has been excluded from blood inflow from the porta as well as backflow from the hepatic veins. However, total hepatic vascular exclusion is almost always associated with major hemodynamic instability, especially in a situation where blood loss has already occurred. So I don't think I have used it in the recent past. And what has been described more often, and I have had situations where I've used it, is selective hepatic vascular exclusion, where you do the Pringles maneuver as well as clamp the hepatic veins. Usually what I've done is I've clamped the right hepatic vein if there's been bleeding from during parenchymal transection. So selective hepatic vascular exclusion is the technique which is now recommended because it doesn't alter the hemodynamics as badly as the total hepatic vascular exclusion. And in most cases, you don't need to do it. A good Pringle maneuver is more than enough. It's only in situations where you have done significant amount of your transection, you are deep into the liver parenchyma in the segment 8 or the segment 7 territory, where it's difficult to see the hepatic veins, and injury at that stage leads to almost direct blood coming from the IVC. So in these situations, the selective or the clamping of the right hepatic vein is very useful. So what I do is I would loop the right hepatic vein and leave a sling around it, but won't clamp it during the liver resection. Coming to Pringles maneuver, because we have students who would be watching this. So this is a simple time-tested technique introduced more than 100 years back, and it's a very useful strategy for reducing blood loss during any kind of major liver resection. It entails looping and clamping of the hepatic the hepatoduodenal ligament in toto. And Pringle's maneuver can be continuous or intermittent. Continuous clamping in a normal liver can be easily, the liver tolerates it easily for up to 30 minutes. Intermittent clamping is being described that you clamp for 15 to 20 minutes and then declamp for 5 to 10 minutes, and can be done multiple times with a total ischemic period of 90 to 120 minutes. That is 1.5 to 2 hours in a normal liver. Even in cirrhotic livers, you can do it for about 50 to 60 minutes. Hemihepatic vascular occlusion or half Pringle has also been described, but studies have shown that it doesn't score over a total Pringle or that conventional Pringle in terms of reducing the blood loss. So whether you do a half Pringle or a full Pringle, it doesn't make much of a difference on your outcomes. So this is just a short video of the Pringle's maneuver. You open the lesser sac, loop the hepatoduodenal ligament with the finger. I use a Foley's. You can use an umbilical tape or a vascular sling, but Foley's is very useful because even in minimally invasive, it works very well. So even in the open, I've now shifted to using a Foley's catheter for doing a Pringle maneuver. It's a very simple step, simple procedure, and it should be done in every major liver resection. You just loop it. I've just for demonstration's sake, I've tightened the Foley's. But you can just leave it loosely around the hepatoduodenal ligament, and as and when the need arises, just tighten it. And you can do it for 15 to 20 minutes, as I just talked about in an intermittent Pringle's maneuver. Now, this is another video where this is a very recent video where I was doing a robotic liver surgery, and this was the bleeding from the inferior hepatic vein, which had already been hemoclips had been applied, had been secured, divided, but then even the hemoclips slip. This I've seen very frequently, and so this was being done robotically. So it's very easy to take sutures robotically. The point I want to make here is that clips, don't be under the false impression that hemlock clips don't slip. They slip very often because these veins have short stumps and very thin walled, and they slip in between the two jaws of the hemoclip. But then don't try to remove the hemoclip. Just take a suture over the hemoclip, because the liver parenchyma tends to tear and rupture, and then it's very difficult to take a suture. And take 2 or 3 bites. Liver parenchyma, if you are not applying too much force, take sutures nicely. So it can be easily controlled section. Just another few minutes, sir. This is another case where I had it's the same video. Sorry. So this is another video where I had a bleeding from IVC. Again, this had been clipped, and it had been ligature had been applied. On top of that, there was a clip. But because this part of the IVC is very near to the heart, so the cardiac pulsations are transmitted, and because of that, sometimes even everything slips, and you can see a big hole rent in the IVC. But again, just have patience. Pneumoperitoneum, as I said, is the surgeon's friend, so the bleeding would have been much more in open. Take pointed sutures close to the vein wall, and it's very easy to suture. So don't panic. Have a good suction and just take a suture. I used a 4O proline. You can use whatever suits you, 5O, but don't use very fine sutures because they tend to, once you're pulling the bleeding point, they will break apart. Once we are talking about parenchymal transaction, we cannot leave this topic without discussing about energy devices. So numerous techniques and devices have been described from the time immemorials that digitoclasia or teleclasia, it's the oldest and still a useful technique, but it's more time consuming, and we have moved on to now so many, because of the technological innovation, so many devices are available. It can be a CUSA, harmonic, vessel sealers, hydrojet and whatnot. But I have been sticking to the time-tested CUSA and harmonic. None of there are multiple randomized trials which have compared these various techniques. So none of the devices or techniques has been found to be superior to even teleclasia or digitoclasia. Although in practice, I find that digitoclasia may be cumbersome. For small resections, it's fine. You can do it with teleclasia, but it's better to use an energy device. Which device to use is a matter of personal choice. I find a combination of CUSA and harmonic, especially in cirrhotic livers, to be very useful. But well, then nothing can beat a CUSA if you want a precision of transaction. Now, this is another video where I had bleeding from the middle hepatic vein during the transaction procedure, and this is how I controlled it. So suctioning is very important. So you need to see the, as I heard in one of the lectures by one of the stalwarts of liver, minimally invasive liver surgery, that bleeding is the nemesis of laparoscopic liver surgery or a robotic liver surgery. So having a good suction, see the bleeding point, loop it, and then apply a clip. Don't try to suture at this point of time because these intrahepatic veins are very thin walled, tend to tear very easily. It's better to apply clips, and then subsequently, if there's some amount of bleeding, residual bleeding continuing, then you can clip it. But the entire idea here is to visualize the bleeding point, have a good suction, loop the vein. I did some transaction before I actually applied the clip. I had not gone around the vein when the bleeding occurred, but you do have time. Don't panic. Go around it, loop it, and apply the. So, just a word about topical hemostatic agents. Multiple agents have been marketed over the years. They can be broadly divided into collagen-based and the fibrin-based. However, there are the multiple RCTs and meta-analysis which have been published in the last 2 decades or so, and all of them have shown that they may reduce the time to hemostasis, but they have no impact on overall blood loss or the transfusion requirement or the bile leaks or the perioperative morbidity. So routine use is not recommended, although they are widely marketed, very popular. In every conference you will find a stall of one of the companies marketing these hemostatic agents. But believe me, over the years I've stopped using them. They cannot replace meticulous vascular control from the cut surface, take sutures, spend time, apply pressure, and all bleeding stop. Once you put on these collagen-based or fibrin glue thing, it makes the entire field messy. You cannot see the bleeding at all. They change color, whether it's a fibrillar you are applying or it's a Surgicel you are applying. Whatever you're using, they tend to change color once they come in contact with blood, and you cannot even see the bleeding point, which was clearly visible previously. So I have used it very rarely, and in our group we do not recommend using these, but again, it's a matter of personal choice. So I would like to summarize by saying that intra blood loss is a major source of adverse post-operative outcomes in liver surgery. It's totally preventable in majority of the cases if we follow the principles. Proper training, good preoperative imaging and planning, attention to details during surgery are the key. Bleeding, once it occurs, can be controlled by simple methods of packing, clipping, and suture. Thank you very much.
Thank you, Shaleen. Dr. Sen, would you like to comment?
Yeah, I would like to make a comment, and I would like to ask 2 questions to Dr. Shaleen also for the trainees. So one comment is, like he's very rightly mentioned, that the traction and the retraction by the assistants is very important because it can lead to unnecessary avulsions and bleeds and even fractures of the liver during the transaction. Now, on these 2 quick questions, like one on practical situation, suppose a large superficial tumor, there is traction, and it perforates on table and starts to ooze and bleed. So this is the first situation. And second is, while you're taping, that is looping the middle hepatic vein, LHV complex, or the right hepatic vein, unfortunately it starts bleeding. So for the trainees, what would you like to do and how would you like to proceed in these cases?
So in answer to your first question, that is where you have a superficial tumor and the capsule tends to or happens to tear. So there will definitely be bleed, but then just don't panic. In these cases, just pressure is the best thing. Ask your assistant to put a gauze piece over the area where the rupture has occurred and press it for a while. And then after a few minutes, the bleeding definitely becomes less. And then you can continue with your procedure. Although oncologically, the situation is bad, you have messed up because tumor dissemination theoretically has occurred. But as far as blood loss is concerned, these tumors don't tend to bleed massively. It would be a slow ooze. And once you have applied pressure, the bleeding clears, the field becomes clear, and you proceed with the procedure in the normal way. In response to the second question, that is, if you have happened to injure the right hepatic vein while trying to, or the left hepatic vein. See, these are low pressure veins, and I have had such situations, and just putting small strategic placement of small pledgets of gauze is the ideal technique. Don't try to continue to loop when the bleeding. You will extend the tear more, and then it will become an unmanageable situation because it's a bleeding which is coming directly from the IVC. So as soon as you encounter the bleed, suck. Try to see the point. Don't try to suture because it's a difficult situation, especially if the bleeding has occurred from the I would say the left side of the right hepatic vein or the right side of the middle hepatic vein, because that area you cannot visualize. And those areas, just put a small pledget, the pressure will control the bleeding 100%. If it's from the right side where it's easily available, like I showed in my video, it was very close to the right hepatic vein, you can gently take a suture and it will be controlled. But if you don't want to take a suture, packing is, liver surgery, the best part about liver surgery, that most of our these bleeds are from low pressure zones, low pressure areas, and packing it should be a very strategic packing, because the pack should not hinder the progress of your surgery. That is the most important point. And I've seen that many a times after 30 minutes, you have done the remaining part of the procedure. When you come back and remove the pack, there's hardly any bleeding, and you can see the rent, and you can suture it under pressure. So
yeah, very rightly pointed out. So basically what we wanted to highlight is that you pack that area, the bleeding would stop eventually in most of the cases, and you can continue with the surgery at the other places.
Yes.
So without trying to remove the pack too early.
Yeah, don't keep on going.
Yeah, and when you remove the pack, please make it wet. We had a long discussion on this yesterday also. Do not try to remove the pack when it's dry, because that can actually have more emulsions. Dr. Ibrarullah.
Yeah, I think I'll just share my inexperience, or say about a liver resection that I did many years back. That was a left hepatic resection. When you start dissecting the triangular ligament, I reached the left hepatic vein, and in my enthusiasm to do a left resection, I looped that vein and ligated it. I mean, put a knot over it. But what I did not realize that I had closed that outflow tract. So in the process, when you're doing a parenchymal transection, there's a lot of oozing and all that, because the inflow was still patent. So what I learned that not, close the outflow tract till you have closed the inflow tract as well. Otherwise, you end up with a lot of oozing and all that during parenchymal
that should
transection.
never be done,
really
because
makes
recently I had a situation.
Sorry?
Recently, I had a situation where there was a tumor thrombus occluding the right hepatic vein. So it was naturally closed. And what I realized, that the transaction became very difficult because of the engorged hepatic vein. And I had plenty of bleeding in that case. So that you have said, that's very rightly said, Dr. Ibrar. But what I would just like to add a point, that don't try to, if it's easy, then loop the right hepatic vein or the middle left complex, but don't fuss over it that before I proceed with the transaction, I would loop it, because if you're finding it difficult, you will definitely injure it in majority of the cases, because it's a blind procedure. It's that only by the feel, it's the sixth sense that allows you to know that, okay, I'm in the right track. Better leave it to the end when you have done significant amount of parenchymal transaction. Better, the most important part is control the inflow. So if the inflow control is there, even if there is some injury to the hepatic vein, the bleeding would be less, definitely much less.
Yeah, funny, I think you rightly said that. Like in another case of my right hepatectomy, when I was trying to dissect that right triangular ligament and then get onto the right hepatic vein to loop it, this time not to ligate, but to loop it. But again, I was finding it difficult, and in the process of dissection, there's a gush of blood, probably had created a rent in the hepatic vein. So thankfully, I applied a vascular clamp, again, little blindly, because there is no access to that area, and that tend to hold the bleeding. And then, of course, I finished all the dissection from the anterior aspect, then went on to the hepatic vein to the end of the dissection and controlled it. But supposing, this clamp did not control that bleeding, then just think of the disaster that I would have ended up with.
Yeah. So another point I would like to add is that majority of the times when you have this bleeding from the insertion of the right or the left hepatic vein, initially it doesn't start from the hepatic vein per se. It is the phrenic vein insertion which tends to get injured, because while you are retracting, they are under stretch, and even a little inappropriate use of energy device would create a rent in these phrenic veins, which then extend onto the main left or the right hepatic vein. So I would like to loop and ligate secure these phrenic veins before actually trying to loop the main right or the left hepatic.
Right. I think that's the point.
I think
any questions? Yeah.
Yeah, Shaleen, two situations which I've faced. One is, we need to talk about the application of clamps, and when the clamps slip from the right hepatic vein. A lot of people, now we are used to dividing it with a stapler, but earlier we used to put clamps, and even now in some situations we put clamps on the hepatic vein, and if one wall of it slips and there is bleeding, so how do you deal with this situation? How do you ensure that good application of clamps should be there? And if such a situation arises, how would you advise to deal with it?
Yes, sir. I have also faced a situation. It is like now you have to differentiate, divide into two parts, whether it's an open surgery or it's a minimally invasive surgery. I'll talk about the open surgery first.
Yeah.
In open surgery, if the clamp tends to slip, then first of all, just don't panic. Ask your assistant to just put your hand or a gauze piece over it. And what I do is I bring in two Babcock clamps and just grab the two ends wherever I'm seeing that blood coming from. I would just grab the two ends because that Babcocks are atraumatic, and then to some degree it controls the bleeding and gives you a traction there. So, and then you can again apply the clamp in a more controlled fashion, lower down, and don't think that you will be occluding the IVC. Forget about the occlusion of the IVC at that point of time. Apply the clamp deeply, as deep as possible, and majority of the times the bleeding becomes less, and then at that time you try taking sutures. And with what I've done in such situations, even if the one wall is slipping a bit, but a little part is, once you have applied a Babcock, bleeding has become less, so the two walls are under your control. At least the slipped wall is partially under control, and then I would quickly take 2 or 3 sutures without thinking how much thickness of the bite I have taken, because at that point I have controlled the bleeding. And once I'm in total control, I'll again reapply the clamp, open the entire suture line, and then suture it in a meticulous fashion, so that no narrowing or the occlusion of whatever vein from which the clamp has slipped has occurred. And in cases of minimally invasive surgery, and what even the stalwarts have described is, don't try to, once the bleeding occurs, don't straight away try to suture it if it's a major bleed. Apply a big clip first on that, because it controls the bleeding at least partially, and then you can take a suture. But ultimately, you will have to take a suture. And secondly, about the clamps, see, these clamps tend to wear with time. So you have to replace your clamps at regular, like you have to check these clamps, because slippage occurs usually when the clamps, the serrations in the clamps have worn out. So the main cause of slippage is that. And so keep on checking your clamps and replace them at timely intervals, especially in a busy center.
Yeah. So, I mean, what I found is that you could use, instead of Babcock, the Ellis clamp.
Yeah, same. So Ellis is sometimes the walls are very thin, and the Ellis has serrations are very sharp. So initially I used to use Ellis. So sometimes the IVC walls in some patients, especially in low albumin patients and chronically ill patients, are so thin that the point where you are holding with the Ellis, that itself lacerates. Then I shifted to a more gentle instrument such as a Babcock.
You should get a good grip, actually.
Yes, that's the basic. Yes, that's
so actually, while doing a recipient hepatectomy, we lost the clamp and there was a gush of blood. So I think not to panic, put a finger, then hold it with a finger, the IVC, put these clamps, lift it up, then apply a clamp nicely, and then once the situation is under control, you could.
And sir, you may also face situations where you don't have access to the bleeding area. You have not gone so far ahead in your mobilization. You just can't see the bleeding. It's just some major
that's
bleeding.
Different.
Yeah, in those cases, just clamp the IVC wherever you find it.
The second scenario I just want to quickly do is, oftentimes, you said fascial or, Lanix, this thing.
Wilsonian approach, yes.
Wilsonian approach. So people use a stapler in that to divide the whole this thing. And sometimes there is bleeding despite application of the stapler from there. So what is your trick, or how do you deal with that and prevent that and make sure that it doesn't happen?
So firstly, I wouldn't venture to put a stapler on a big pedicle unless significant amount of transaction has already been done, because not only that bleeding part, I'm more worried that my stapler can encroach upon the remnant pedicle, because these areas are, like, I would say hardly 2 to 2.5 centimeters. So I prefer to use a Setinsky clamp or any other Potts clamp and then divide it. And suppose your staple line is bleeding, then these bleeds are not very torrential bleed, and usually it's an arterial bleed in such situations, and you can easily locate under magnification the artery. And if before taking a suture, apply a vascular clamp on that pedicle. Just pull it up, take a blind suture, use it as a traction suture, apply a Potts clamp, which is a fine clamp, and then under vision, underrun that suture line, and the bleeding will become.
Yeah. Many people say that you apply, if you have enough space, put a clamp, then put a stapler. At least you have control over it. It will not retract back and have problems. So you can have that.
I don't prefer using staplers in that area. Clamping and then cutting and suturing is the best. It hardly takes any time.
Shaleen, one more additional point, like when Sadiq was saying, when the clamps clip, I mean, especially in the transplant scenario, in the donor or the recipient, when you have at the end of the surgery, you have multiple clamps lying there, and you might have to take some time to come back. One useful tip is, which we also use, is in the middle of the vein, just take one single Prolene stitch and leave a long stump on it. When you have hepatic vein, that will, so in case they slip also, you'll immediately pick up that and
something for traction. Agreed. That is it's a useful technique.
Thank you, Shaleen.